This video is all about how polycystic ovarian syndrome impacts the menstrual cycle. I have other videos that gets much more into detail about some of these things that I've linked in the description. This is just a very broad overview. So the menstrual cycle is actually made up of two separate but simultaneously occurring cycles. One is happening in the ovaries and it's called the ovarian cycle. And one is happening in the uterus and it's called the uterine cycle. And hormones from the ovaries actually impact the uterine cycle. So let's start in the follicular phase when gonadotropin releasing hormone is being released from the hypothalamus and stimulating the pituitary to release LH and FSH. So what normally happens is that LH stimulates the theca cells of the follicle to create androgens. An example of an androgen is testosterone. And then those androgens move inside the follicle into what's called the granulosa of the follicle. FSH comes in and through the action of aromatase converts androgens into estrogen, and then estrogen leaves the follicle. So this is happening to multiple follicles at the same time. They're all being stimulated and they're all releasing just a little bit of estrogen. This little bit of estrogen being released actually exists in a negative feedback loop and turns down the FSH. So negative feedback loop is something downstream turning off something upstream. So the FSH gets turned down. With the FSH getting turned down, what that actually allows for is one follicle to become dominant and to start really being stimulated and to start releasing a lot of estrogen. The little bit of estrogen being released, it created a negative feedback loop with FSH. But this high sustained release of estrogen actually causes a positive feedback loop with LH. So it turns up the LH and it causes what's called an LH surge, and it makes this follicle, the dominant follicle, rupture. And then you have ovulation because the follicle, the egg house, has ruptured. So you have ovulation, which is egg release. This is what normally happens. Moving on to the luteal phase. That ruptured follicle is actually now something called the corpus luteum. So I'm going to draw it. This is a ruptured follicle underneath the luteal phase. It reorganizes itself into something called the corpus luteum, and it doesn't look like a square box, but I'm just drawing it like that so it looks like something organized. And the corpus luteum releases hormones all on its own. It releases, so I'll put Cl here so we know it's the corpus luteum. It releases estrogen and it releases progesterone. We have another negative feedback loop here. The progesterone released by the corpus luteum actually turns down the gonadotropin releasing hormone. So I'll put negative there for negative feedback loop. And the body does that so that ovulation doesn't happen twice in the same cycle. Okay, so we have progesterone and estrogen being released from the corpus luteum. If the egg is not fertilized, the corpus luteum actually breaks down. So then, of course, because we don't have a corpus luteum anymore, we get a drop in estrogen and a drop in progesterone. And now we've reached the end of the luteal phase. So that's our ovarian cycle. Now let's see what's happening in the uterus during all this. Because we've had that drop in progesterone and now we're on day 28, like I said. So we're coming back to day 1. I'll put drop in progesterone. The uterine lining sheds, the endometrium sheds. And the reason is because progesterone maintains the lining. And so when it drops, the lining collapses. So shedding of the endometrium. Day 1 of a woman's cycle is the first day of her period. So we're on day 1, the menstrual phase, and we're back at the beginning with the follicular phase. So the follicular phase and the menstrual phase are happening simultaneously. All right, let's move on to proliferation. The proliferative phase happens between days 6 and 13. And this is where the ovaries are really going to start impacting the uterus. So we have all that estrogen being released from the follicle in the follicular phase here. This estrogen, actually, I'm going to draw an arrow over here to the proliferative phase because this estrogen stimulates the growth of the uterine lining. Growth of uterine lining. So it's been shed in the menstrual phase, but now because we have that high sustained estrogen that's coming from that dominant follicle, we are able to grow the uterine lining again. So the endometrium becomes thick. It's not ready for implantation yet, but it becomes thicker. Okay, now we're in the secretory phase. And here again, our hormones from the ovaries are going to impact the uterus. Notice we have progesterone and estrogen coming from the corpus luteum. Well, those actually play a role in preparing the uterus for implantation. So we're going to stabilize the lining here. Mostly progesterone does this, but estrogen plays a role in it as well. And that happens from days 15 to 28. So that's a very broad overview of the menstrual cycle and some of the feedback loops. Now let's talk about what's going on in PCOS. So I'm going to draw PCOS in red. When you have PCOS, you have more luteinizing hormone than the average person does. And I'll draw it over here. And it's because you have more fast pulses of gonadotropin releasing hormone. So you have increased luteinizing hormone. You have the correct amount of follicle stimulating hormone. Your follicle stimulating hormone isn't low, but it's relatively low, meaning you don't have enough follicle stimulating hormone for all that luteinizing hormone. And remember, it's the follicle stimulating hormone that plays a role in turning androgens into estrogen. So if you have increased luteinizing hormone and a relatively low FSH, the next step in our pathway is going to be increased androgens because we don't have enough FSH to deal with all that LH. Because we have increased androgens, that means we don't have the negative feedback loop. No negative feedback loop, which is the loop that turns off the follicle stimulating hormone. So that means we continue to get a release of FSH, and that means that no dominant follicle develops. So the analogy would be if we're trying to just grow one tree, we would just water that one tree and it would grow really big and strong, and that would be the dominant follicle. Well, if you spread that water over, let's say 10 trees, none of those trees is going to become big and strong. So that's kind of what's happening here. We're watering 10 trees with follicle stimulating hormone instead of just watering one and letting that one become dominant. So we have no dominant follicle, which means we have multiple small follicles. So they're all a little bit stimulated by FSH, but nothing is stimulated enough to become dominant. And this is where the name polycystic ovarian syndrome comes from. You have multiple small follicles. Okay, so because we have multiple small follicles, that means we don't get the big dose of estrogen that we do from the dominant follicle. So I'll say no big, and I'll put in quotations, dose of estrogen. And by dose, I mean that because there's no dominant follicle, there's not one follicle releasing a whole bunch of estrogen. So that means we do not get the positive feedback of LH. And of course, that means we don't get an LH surge. and we do not get ovulation. No ovulation. Because we do not have ovulation, because we don't have a rupture of a follicle, that means we have no corpus luteum. And remember, it's the corpus luteum that releases estrogen and progesterone. And it's mostly progesterone. Without progesterone withdrawal, the endometrium does not shed normally. So I'm going to go back up. Now we're at the menstrual phase again. So normally in the menstrual phase, we have that progesterone withdrawal. So no progesterone withdrawal. And this is going to lead to one of the features of PCOS, which is absent or irregular menstruation. And I'll write periods here, absent or irregular periods. All right, let's move to the proliferative phase. Now, normally in the proliferative phase, that estrogen from the dominant follicle causes the growth of the uterine lining. Well, in PCOS, we have many, many follicles being stimulated. So we do have some estrogen, but it remains low to moderate, and it's not cyclical like it's supposed to be. So I'm going to draw an arrow from my estrogen in the follicular phase, coming from that follicle, over here to the proliferative phase. And because of this estrogen, the endometrium does grow. The uterine lining does grow, but we don't have the progesterone coming from the corpus luteum to stabilize the lining. So I'm going to put a big X through these blue arrows going to the secretory phase. I'll draw an arrow here. Endometrium grows, no progesterone. So the endometrium becomes, you're going to see the word disorganized. So that basically means that you do have estrogen making the endometrium grow, but you don't have progesterone to really tell it how to grow properly, so to speak, to organize it, to stabilize it, to differentiate it, basically telling it how to grow properly. So we have a disorganized endometrium. And so actually the secretory phase that really relies on progesterone doesn't truly happen in PCOS. And again, that's because the secretory phase relies on progesterone. All right, so in the middle of this, I have the normal menstrual cycle, and in red on the outer edges, I have what's happening in PCOS. Now let's talk about how doctors actually diagnose PCOS, and they diagnose it with something called the Rotterdam criteria. And you need 2 of these 3 things to be diagnosed with PCOS. First one is ovulatory dysfunction. And now that we understand how PCOS impacts ovulation, in that ovulation doesn't happen, we can understand why that's part of the diagnostic criteria. Now, it's really hard to tell unless you're doing blood work and sometimes invasive tests. It's hard to tell if someone is ovulating or not. So the way clinically this ovulatory dysfunction shows up is irregular cycles. So instead of a doctor figuring out if you're ovulating, they might look at your menstrual cycle as kind of an indirect way to see if you're ovulating or not. It could manifest as cycles greater than 35 days apart. Of course, it could manifest as just completely missed periods, no periods at all for months and months at a time, less than 8 periods per year, and infertility. from anovulation. So the diagnostic criteria is ovulatory dysfunction. Like I said, it can be hard to figure out if someone is ovulating or not. So sometimes doctors will look at clinically what the woman is experiencing to understand if they are ovulating or not. Second part of the Rotterdam criteria is hyperandrogenism. And now we can understand why women with PCOS experience high levels of androgens. It's because they have a lot of luteinizing hormone to tell the follicle to make androgens, but they don't have enough FSH for that amount of follicle stimulating hormone. Let's review that. There's a follicle. The outside layer of the follicle is called the theca, and the inside layer is called the granulosa. I have LH and I have FSH. LH tells the theca cells make androgens, and then the androgens move into the granulosa. Then FSH comes along and it tells those androgens through the action of an enzyme called aromatase to turn into estrogen. And then, of course, estrogen is released and we get our negative feedback loop and then our dominant follicle and then our positive feedback loop. Well, in PCOS, you just have a lot of luteinizing hormone, which means you have a lot of stimulation of those theca cells. And then instead of the follicle secreting, we'll say, estrogen, it actually secretes androgens. Because although you do have FSH, you just don't have enough to cope with the amount of androgens that are floating around. So you have androgens being released from the follicle instead of estrogen. An example of an androgen is testosterone. An example of an estrogen is estradiol. I'm just using the broad words here, but estradiol is actually the estrogen that we release from the follicle, that reproductive age women do anyway. Okay, so how does these high levels of androgens clinically present in people? Alopecia. In particular, what's called male pattern hair thinning, acne, because testosterone has an effect on the sebaceous glands of the skin, and something called hirsutism. And that's a condition where women grow hair on their faces. There's other ways to check for high levels of androgens instead of just looking externally. On a lab test, a blood test, increased total testosterone and increase free testosterone. So that kind of represents the excess stimulation of the theca cells. Third criteria, according to this Rotterdam structure, is polycystic ovaries on an ultrasound. Ultrasound is a non-invasive test. And if this test is done, the doctor would be able to see rows and rows of follicles. They're actually described, you'll see them in textbooks and stuff, described as looking like strings of pearls. And that's representative of these follicles that are getting a little bit of FSH. They're all getting a little bit of FSH instead of one becoming dominant, multiple small peripheral follicles, and perhaps even enlarged ovaries. So PCOS, some people don't like the name because they're not truly cysts inside the ovaries. They're just immature follicles that never become dominant. All right, let's review what we've learned here about PCOS. The menstrual cycle is actually 2 cycles happening simultaneously, one cycle happening in the ovaries and one happening in the uterus. Overall, we are going to be growing a dominant follicle. That follicle ruptures, it rearranges into the corpus luteum, and all the hormones involved in that have an impact on the uterus. When an individual has polycystic ovarian syndrome, for a multitude of reasons, they have increased luteinizing hormone. And although their body is not making not enough FSH, it has a normal FSH. It's not enough FSH for the amount of luteinizing hormone. So that's why you'll see and read relatively low FSH. Because of all this, the individual has increased androgens, which means the feedback loops are going to become deranged. They don't work properly. And all in all, there's no ovulation and no corpus luteum. That's going to impact the uterus because it's the progesterone withdrawal that makes women have their periods, that makes them shed their uterine lining. The endometrium is going to grow it's not growing properly. It's very disorganized. And that's actually a complication of PCOS. It's called endometrium hyperplasia. So the tissue is growing and growing, but it's not growing properly. It's never shedding. The secretory phase does not happen. To be diagnosed with PCOS, you need 2 out of 3 of the Rotterdam criteria. It could be any 2 out of 3. Some people might have 3 out of 3, but you need at least 2 out of 3 to be officially diagnosed. Ovulatory dysfunction, which manifests as all sorts of problems with menstruation. Hyperandrogenism, which manifests with different clinical signs and symptoms: acne, facial hair growth on women, male pattern baldness, thinning hair on women, and of course the lab tests are going to show an elevated testosterone too. And if you had a ultrasound, you might even see a whole bunch of immature follicles inside the ovaries that have grown a little bit, but have not grown enough for any of them to become dominant. So that's an overview of PCOS and the menstrual cycle and the Rotterdam criteria.